Assalamu alaikum. Good morning, everyone. Thank you, Dr. Alan. Thank you for the panelists. It's a pleasure for me to be here again for the third year for ADOR. And being a VR surgeon, I've been not attending any anterior segment conference since a long time, so it's a good pleasure. We had very good experience. I have a lot of excellent talks yesterday and tomorrow. So in my talk, I will focus mainly on the how to manage the vitreous loss, how to perform anterior vitrectomy in a safer way. So what should we do and do not do dealing case of this vitreous loss? First of all, we should know our target. And I think this rule should apply in our life, generally speaking, not only for anterior vitrectomy. Second thing, you have to expect complication before going to the surgery. And then intraoperatively, it's very important to recognize early signs of vitreous loss of posterior capsule tear, so you can interfere early. And then definitely we have to know your technique and the setting for the machine. And finally, we have to get a proper post-operative care. So if you start doing, knowing our target actually here you have to think that we are not going to do a total vitrectomy or complete vitrectomy. We are just want to remove the vitreous in the anterior chamber. And we need to assure these items. What we want to do is prevent intraoperative vitreous traction, either to the wound or to the iris. This is the most important point. And then at the end, maintain normotensive globe. This is very important for the post-operative inflammation. Protect tissue like cornea, iris during doing the vitrectomy and the capsule for sure. And finally, you have to remove any remaining fragments for the sake of post-operative inflammation or reaction. Expect complications. It's a very important point because during preoperative evaluation, there are some problematic eyes that will not expect to not go smoothly during surgery. We have a list here: low zenures, myotic pupil, glaucoma, hemiotraumatic cataracts, victromatized eye. Those kind of cataract or patient, you should have a little bit more extra care, or you have to expect something might happen during the surgery. So what we can do, this is an example of the, as Dr. Akahoshi said, the wrinkling of the posterior capsule during cystotome or capsulorhexis. This is early sign of weak zenures. So in this case patient, I prefer to consider peripubic. I know that my colleague, anterior segment surgeon or cataract surgeon, usually you like to do the cataract in 4 minutes or 6 minutes, I believe that, and also on topical anesthesia. But in some patients like this, if you're expecting to have some difficulty, it will not harm anyone if you consider peripubic or even subtenuous anesthesia, just in case of anything wrong happen. Keep vitrectomy beside you for sure. Stay not to search for it during the surgery. And backup implant, very important, because maybe you have some cases that the power of the lens is not common one, so you have to prepare in advance 3 pieces or something like that to help you. So early recognition of warning signs, I thought it's very important point here. You have to recognize those signs early. It will help you a lot. For example, one of the most important signs is the change in the depth of the AC. Suddenly you find sudden deepening of the anterior chamber, and this means that the posterior capsule might be opened. Another important point, the flowability of the lens material is not smooth anymore. And this is very common. I see this, the phaco, if you didn't recognize there is vitreous loss and you keep continuing doing phaco, if you find that the phaco tip is blocked and you give this sound, the machine gives you sound of occlusion and there is no fragment, so you have to think that something going wrong. You are catching vitreous or something, so you have to stop at this point and check. Tilt of the lens equator, this late sign actually, to be honest, it's not at early. And you can sign spinning of the capsule or unusual clear spot. It means the posterior capsule might be open at that time. Peak the pupil also is another sign of vitreous loss. So the message here, if you recognize these signs early, it will help you to stop and manage it properly and do not proceed for more complications. What about the technique and setting? This is very important. As I told you, if you already this patient on topical anesthesia, you have to give some more block because patient with pain will be positive pressure and more vitreous will come out. So consider them. The most important point to my mind here, once you recognize there is a vitreous loss and your phaco probe inside the eye, the most important thing is not to let the anterior chamber collapse. So how we can do that? You have to do not pull the phaco probe out of the eye. This is, sometimes normal reaction for junior doctors. Every side, wow, it's a complication, so I have to get out. No, this is not the case. What you want to do is just to stop vacuum and to keep the irrigation on. If you have to position, according to your phaco and the phaco machine or vitrectomy machine, go to step 1 usually, and while keeping the probe inside the eye, with the other hand from the sideboard, you can inject viscoelastic behind the fragment. Why doing that? This will increase the pressure in the anterior chamber and prevent more vitreous to come out. Just a cartoon to show you what's happening here. You can see here, this is if this vitreous loss, the anterior chamber lost pressure, vitreous will come out. So if you keep the probe or the flow inside the eye and inject viscoelastic behind the lens, this will keep the pressure in the anterior chamber high and so prevent more vitreous loss. Proper setting, very important. Our main technique, our main thought, our main objective to decrease the traction, as Dr. Benjamin said that. So we need to use a proper setting for the machine to decrease the traction. What is the most important? To use the highest cut rate available in your phaco machine, or if you're using vitrectomy machine. So I think the machine now, as an anterior vitrectomy probe, we have 5 cuts per minute, I believe. And you should low flow irrigation and lowest vacuum to remove, because as I told you, we don't want to remove the whole vitreous, we just remove the vitreous anterior chamber only. So the high cut rate is important. Vitrectomy mode, we now have most of the machine now have 2 modes, either IA cut, which is cutting irrigation doing cut, and then the vacuum cutting first and then aspiration. This is usually used for the vitreous because this will limit or decrease the traction. If you want to move the fragment, we're sure we need more vacuum, so we have to convert it to cut IA, which is a vacuum first and then the cutting. This is just to show you the foot pedal according to the machine. So Kinalog is a very important, Framingham is a very important tool. You can use it to visualize the vitreous, the anterior chamber, and Dr. Benjamin will talk about that. So what is our approaches? If you're going to do anterior vitrectomy, we have 2 main approaches. Either paracentesis anterior vitrectomy, which is commonly done by the anterior segment surgeon, and the paraceplana anterior vitrectomy. What is the rationale for the paraceplana? Personally, I believe that approach. Because, it makes more sense anatomically. You are approaching the vitreous paraceplana, you are more anatomically there, and also this minimizes the traction by being very close to the vitreous base. And it's most efficient because you are calling the vitreous back home again. Also, you can remove the vitreous with less damage to the iris or the capsule because you are coming from behind, and you need to sweep the vitreous from the side ports or incision. So this is just to show you a cartoon here to show this technique. This is the paracentesis paraceplana, and this is the anterior approach. And a new very important tip here is use separate incision for vitrectomy. Do not use the vitrectomy probe through the main incision because it will increase the leakage. Just a small video to show you how to do that. It's not my own video. I just brought it to show how it goes on. Just go with the trocar and 3.5 millimeter Liebmann, and more the machine now have in the anterior vitrectomy bag, there is a trocar there. And you can do the vitrectomy here, looking for the remnant. You can see it's more anatomically, make more sense for me. And you can use either the IA to remove the remaining cortex, or personally, I believe to use a vitrectomy probe itself to remove the remaining the lens fragment, because if any traction or you aspirate or you catch by mistake or by chance any vitreous, you can go down and cut rather than aspirate and get out. The next or the other approach is the anterior vitrectomy, and here it's very good. You can see here using triampsilon. It's very important to visualize the vitreous. Make sure that you remove all the vitreous at the end, and you can go with the from the paracentesis. And I told you, please do not use the main incision for the vitrectomy probe because it will increase leakage, and you will. It's very important to work in a normotensive globe pressure. And then use the vitrectomy probe itself. You can remove the remaining of the lens fragment. It's more efficient. And sometimes, if you find more leak, you can take a suture in the main corneal wound, just to maintain the pressures. Another important advice here, which is seen, do not shave the fragments. Sometimes if you are feeling, if you saw the vitreous loss and the operculum is open and some fragment is there at the, behind the capsule, most of the doctors trying to chase it, to go around with the vitrectomy probe or whatever, any instrument. I don't recommend that at all. So, because you are exerting a massive vitreoretinal traction. So do not cause retinal tear. Just stop at this point and don't be worried about any fragment fall down the vitreous, because they can refer it to the VR, or if you have VR surgeon the same day, you can help you. So this is a very important point. Do not chase or don't play around the fragment while there is posterior capsule tear. Definitely, we have to stop now doing any more sponge vitrectomy. This was in the history, because this really exerts very aggressive pressure or vitreal traction on the vitreous spaces, specifically, and high incidence of retinal tear post-operatively. So the final step, as I told you, after removing the vitreous, the residual cortex, you have to remove it. As I told you, we have two techniques, either the vitrectomy probe or with the IA. But make sure that to prevent collapse again, any collapse or any lost pressure in the anterior chamber at any part of the surgery after vitreous loss, it will bring more vitreous. So you should keep in mind that the anterior chamber pressure should be, let's say, normal intensive at all the time. IOL implantation, for sure, we have different choice. It's up to you, whatever you want. If you're not happy, you can leave it aphakia for another implantation, no problem with that. And finally, use some myotic to constrict the pupil and stabilize the IOL and to guarantee water diet. Post-operative care is very important. What I want to focus here, you have to give this patient non-steroidal anti-inflammatory drugs to guard against post-operative pseudomacular edema. And definitely you have to refer to a retinal specialist to check if there is any hole or tear. Most important for myself is the last step, the last point here. You have to disclose this to your patient. There's something happened, we manage it properly or whatever, because they will know anyway. So you have to, because this patient might did cataract in the other eye and he didn't feel. He will experience maybe some floaters or complication might happen. So you have to disclose the patient what happened and ask him by himself to check his vision, peripheral vision at home. So we have now, what is the take-home message now? As I told you, we have comprehensive strategy in this anterior vitrectomy, meaning that we have pre-op and post-operative care. With this comprehensive strategy, with preparing in advance for loss of vitreous and you're expecting complication, you can treat your patient with logic and care. And this is the most important, and all this will lead to, at the end, to achieve your optimal outcome, even complicated care. And thank you for your attention.
Thank you very much, Dr. Baraki.